Hi, I'm Kyle Rove, a pediatric urologist at Children's Hospital Colorado.
And I'm Nick Cost, a pediatric urologist and urologic oncologist at Children's Colorado.
So Nick, one of my interests is enhanced recovery after surgery, and you recently published a study on this topic. Do you want to tell us a little bit about it?
Yeah, I appreciate the opportunity to do so, and really it's building on a lot of the work that you've already done with the group here and with Dr. Wilcox, specifically on enhanced recovery as in regards to reconstructive surgery. And we were looking for ways that we could potentially expand that. And while the surgeries are different in their scope and aims than reconstructive surgery, when it comes to oncology, there's a lot of the similar things that we're doing, as far as in the abdomen and how invasive the procedures are. And so it seemed to make a lot of sense to try to extrapolate those findings. And so what we tried to do was just be very objective and look back at the experience here and see how patients did and try to set some benchmarks as far as, well, how would we like them to recover? How long would we want them to stay in the hospital? What are the components of that you've already demonstrated are important? And so we looked at each of those, basically trying to determine if they did impact time to discharge and return to adjuvant chemotherapy, things like that.
And are there particular things that stand out? Do you think that patients, when they're undergoing these operations, might benefit from your work, your research?
Yeah, we weren't able to demonstrate a lot of things were very helpful. We were able to demonstrate actually more things that didn't seem to make any difference. Some of the dogmatic things that you've already demonstrated in some of the reconstructive surgery, things like prolonged NPO times before surgery, prolonged NPO times after surgery, NG tubes, bowel preps, things like that had no beneficial impact on length of stay. And I think families and patients feel better when they're having the carbohydrate load before surgery, when they're being returned to eating right away. They're not tortured with an NG tube. Also, I think they're more comfortable with the regional anesthesia that has become a big part of the enhanced recovery protocols.
Yeah, I think you and I know that the surgery tends to affect patients, their physiology of a patient dramatically, and we know of ways to prevent that, but I also think there's also the mindset that goes along with surgery and how that tends to impact patients and how they feel about their experience around the time of surgery. And the things you just mentioned, like drinking liquids up to the time of surgery within certain time limits, and then early feeding afterwards, and not having other drains or invasive devices placed on them after surgery seems to, in my experience, really help them sort of psychologically through the experience a lot better.
I totally agree. I think that surgery itself is a traumatic event, but we should try to reduce that trauma as much as we can, and I think that includes reducing the time that trauma takes place. And when we starve them for hours beforehand, we keep them NPO with an NG tube for hours afterwards, we're prolonging that traumatic impact. And I think what we've seen, what you've shown with your work as well, is that when we try to make the surgery as brief of a blip as possible, they do better. And that makes sense, but it challenges, decades of dogma.
One thing I found interesting with your recent paper is that you put it in the context of trying to reduce recovery so that they can get adjuvant therapy. Can you talk a little bit about that?
Yeah, it's long been a goal of the pediatric oncology protocols to have them start adjuvant therapy as soon as they can. And I think that it, again, is part of that same hope that we're reducing the length of time that these kids have to have these treatments, and if we can get them out of surgery onto their adjuvant therapy and get that done as quickly as we can, they're going to do better. And there are also data that essentially, the more you dose condense their therapy, they're going to do better. So if they can recover well, they're strong enough to start their adjuvant chemotherapy, they can get it in a timely manner, they're going to do better. And I think that as surgeons, when it comes to cancer care, it's often that people don't think, well, we're impacting their long-term therapy, but in reality, we need to think of ourselves as an integral part in that, and how what we do ultimately impacts some of the systemic therapy that we may not be as intimately involved in.
One thing I've noticed through the work on enhanced recovery is that it strengthens the relationship of the surgeon with the entire team, because we lead the effort to promote recovery after surgery, and I think the patients recognize that, and I feel like I've had a stronger relationship with patients when I do that. What has been your experience or thoughts about that?
Yeah, I totally agree. I mean, some of it's even in the terminology, right? The enhanced recovery after surgery. So I think for a long time, surgeons thought of themselves as this, player for this one specific part. We come in, it's a very technical exercise. We do what we do here, and then that's it. And I think that, you and I both really enjoy that part of the preoperative experience, the postoperative experience, getting to know these patients and their families. And by engaging them from the very beginning, tell them we're going to work on this part before surgery, we're going to work on this part after surgery. It really expands our interaction with them, and they feel invested. They're a stakeholder in this, that, okay, we're going to be in charge of doing the preoperative regimen. We're going to be involved in this postoperatively. And so I totally agree. It strengthens that relationship for sure.
And how about thinking to the future, like future research possibilities with regards to enhanced recovery after surgery? Where do you see that going after your study that you published?
Yeah, I think as with all work, right, it needs to then transition from a retrospective look back to prospectively implementing these things that we know can make a difference. And it probably needs to be multi-institutional, because these are rare conditions and fairly rare surgeries. And so to collect any meaningful numbers, we're going to need to work together. And I would say that strengthens the field as a whole, similarly to what you just mentioned about engaging with the families at the beginning and then during surgery and after surgery. I think engaging the whole community with these ideas makes the whole field better, because as we protocolize our approaches and standardize them, I think we've seen across the board in surgery, patients do better when we approach things in a standard fashion. Variation and care may make you unique, but it doesn't seem to help the patients very much.
Absolutely. A lot of people have reached out to me from our colleagues to pediatric anesthesiologists who are very interested in this field but aren't currently doing enhanced recovery. Have you had any contact with other pediatric urologists who specialize in oncology, who are interested in trying to apply these principles at other centers?
We've talked about it some. I think the hurdles are just like what you faced when you started this program, that people are curious, but they have so many preconceived ideas and hurdles that they almost put up for themselves. Well, I'm not going to be able to do this because my anesthesiologists won't do this, or we'll never get preoperative, the preoperative area to allow them to do this. We won't get the pain team afterwards to do this or that. And you have a lot of focus on what can't be done. And so I think the work that you've done just demonstrates this. Yes, it can be done. It just takes identifying those key stakeholders and all the relevant groups and making it happen. I mean, the inaction on it is what ultimately keeps it from happening. But I think as we continue to demonstrate that it's a helpful thing, what will eventually happen is that the families and patients will drive its necessity, because they'll realize that it's something that's helpful and they won't settle for something less.
Now, I talked a little bit about strengthening the relationship between the surgeon and the patient, but I've also seen that by implementing this, the surgeon also leads an entire healthcare team. So we interact with anesthesiologists, nurses, nurses on the floor, pharmacists. And the program, when you implement it, tends to involve all of those components, and thereby requires that the surgeon interface with those people in the hospital, whereas before, we might just place an order and expect that the pharmacist does it. We don't necessarily know who the pharmacist is, whereas after implementing this, I've noticed that I am much more aware of my colleagues in the hospital and have a better relationship with them, which I think impacts patient care.
Yeah, I couldn't agree more. I think it builds on that multidisciplinary relationship that I've very much advocated for all along, and some of the other research we've done looking at the surgeon's relationships with pathologists and how that impacts the pathologic diagnosis and outcomes. Also, when it comes to oncology care, it's been such a culture of multidisciplinary care with oncologists, with radiation oncologists. I think that approach in general is invaluable, and it goes on behind the scenes. The patients don't see it, but I have no question it impacts their care. And again, I think we need to think about ourselves as more than just surgeons. And this is a way to do that and to lead the healthcare team. I think it's a great opportunity to interact with more people around the hospital.
Absolutely. Do you have any thoughts about how to approach surgeons or other healthcare providers who are hesitant to implement enhanced recovery after surgery pathways?
Sure. I mean, I think your group in doing it with the reconstructive surgery has been very mindful that people are going to have some hesitancy. They're going to have their own prejudices ahead of time of what they do or don't want to do. And I think it's important to realize that it's a bundle of things that help. The enhanced recovery system is a bundle of things that help. But it's not as if it's an all or none game, that you either do it all or you don't do any of it. That it can be scaled and used as to what you can accomplish. And if you can't do all 20 elements of the program, but you're doing 15, that's still a win. If you're only doing 10, that's still better than not doing any of them. And so I think when you approach it with that attitude, it's very easy for them to get on board. And also I think it's important that we don't tell people that if they're not doing it, they're doing something wrong. You want them to see it because it's a beneficial thing and they want to come around to it, not beat them over the head that you have to do it because otherwise you're behind the times. And again, over time, just as I think the families will push for it to be an integral part, I think physicians will look around and they'll say, I haven't adopted this, I'm really behind. And it will happen organically on some level.
Yeah. So you brought up an interesting point about whether you have to do all of the items in an enhanced recovery pathway or not. In my experience, like you mentioned, you can omit certain things when it's clinically appropriate, or say a surgeon or an anesthesiologist doesn't feel that it's indicated, and still get the benefits of the other items in the pathway. Can you talk a little bit about that?
Yeah, again, I think it's important to realize that while we want to standardize and develop protocols for patients, every patient is different and they're unique and they will need some personalized care, and they're not going to fill every element of what we might want to do in the protocol. And so, for example, the minimally invasive surgical part of it, I think that's a great help in some instances. But when it comes to oncology surgery, there's not uniformly a use for minimally invasive surgery. And so that element may not apply to every case. And we would love to use it when we can, but we can't always. And so we don't want to tell the surgeons you're going to have to do every one of these elements to really qualify for ERAS. And so keeping an open mind about what elements are helpful is an important thing. And I just think it serves as a framework to approach the patients, with our ultimate goal on the back end being the same. We want these patients to recover as well as they can. Not necessarily as quickly. I mean, I think that there's a lot of emphasis on time because it's an objective metric that we can study, and it's a great thing. But whether it's 4 days in the hospital or 5, if it's that 6th quality day is at home, I think that's the important thing. Or 2 weeks later, they're feeling great, regardless of how long it took them to get there per se. So for research means, I understand we have to make it very objective. But I think in some ways this is all about the experience of the patient and the family, and that can take a lot of different forms.
Yeah, I explained to families and our team that when we take care of patients on the pathway, that the pathway is meant to be flexible, and there should be, if there's clinical needs for, or needs to not do something, then they should do that and not feel bad about it, but still realize that in a bigger context, we still want to apply the pathway as much as we can where it's appropriate. Right. And sometimes that's a mental hurdle. I feel like some of the team members or maybe families have to get over. They're like, oh, we weren't able to do one part of the pathway. Does that mean we're not on the pathway? And I have to explain to them, no, actually, it doesn't. We're still going to do everything else possible to make sure your son or daughter recovers as quickly as possible.
Yeah, I completely agree.
How do you envision this program expanding the use of this program to other centers, sort of expanding the knowledge so other surgeons can take advantage of it?
Yeah, I mean, I think that the dissemination of knowledge is a difficult thing sometimes. I think we can present our data at meetings. We can have sessions on these topics at our conferences. I mean, we've done some of that. You've done some of that already in regards to reconstructive surgery. Within some of our oncology sessions, I can foresee us having sessions on this, how to roll it out at your own institution. I think research is a great way to do that because people have a buy-in to do it at their own institution. It comes with a framework that they know how to apply, and then there's a lot of knowledge gained. But I think one of the more important parts is probably how do we disseminate this information to families, into the end consumer, the patients and their families. And I think things like this, reaching out to the community, talking directly to families about it, I think that ultimately it's they who benefit, and so we need to get that information into their hands. And so working with advocacy groups I think is an important thing to do. And so as we have more data to provide, I think we'll do more of that, but I think it needs to be really two-tiered. It can't be just to providers or surgeons, it can't be just to families, it needs to be to both.
Absolutely. One thing I like to emphasize with families when I talk to them about enhanced recovery after surgery is the pain control aspect, that it's multimodal, meaning we do a lot of different things to help and make sure that their child is as pain-free as possible, in the context of surgery. I try to emphasize that no pain is not necessarily the goal, but that some pain is always going to be necessary or a part of surgery. But the goal of surgery, of the enhanced recovery after surgery pathway, is to minimize pain as much as possible. Yeah. And pain within oncology has some connotation with regards to patients might be more sensitized to pain. How do you sort of envision the pathway as it applies to pain within your patients who are having surgery?
The whole ERAS pathway is getting people back to where they were before surgery as quickly as they can. And so the multimodal pain part feeds into that because we want them to be comfortable. We want them to be able to return to the activities they can as quickly as they can without pain. And so we like to use things that are non-overly sedating. We like to use regional blocks, especially ones that may not affect their walking, for example, so that we can get them back to moving around. And that really takes two different things. They have to be able to be ambulatory, but they have to be pain-free enough that they feel comfortable being ambulatory. And I think that that's something that we want to emphasize to patients that, the day after surgery, we want you trying to be back to some of those activities that you're already doing, up out of the bed, in the chair, walking if possible. And so that is a fine balance between pain control, but not so much pain control that they're not able to do the things that we want them to do. And so, I think talking about that with them beforehand is important, and especially when you've been dealing with cancer patients, as you've mentioned, that may have had a lot of pain leading up to their diagnosis or during the period that they may have had pre-surgical chemotherapy. And so we try to put that all into a context of we want to get you back to good, where you were before this all started. And surgery is a part of that, and the recovery is a part of it, but let's minimize that as much as we can.
Absolutely. It's been really interesting talking to you about this. To learn more about enhanced recovery after surgery, we are available here at Children's Hospital Colorado. We're available to our colleagues within surgery, pediatric urology, and we're open to patients who are interested in this topic. Thank you.